This next video clip on examination basics will look at some of the basic examination procedures for lumbar flexion. It's a movement that's commonly restricted, sometimes unstable, and oftentimes painful for our patients. In clinical practice, we need to look at lumbar flexion first with our patient in a standing position. And in clinical practice, this shirt gets rolled up and tucked up so that we can see the skin from T12 all the way down to the base of the sacrum. Okay, make sure you do that in clinical practice. For our video clip, the shirt's going to stay right here. Okay? We have to have our eyes pretty close to the lumbar level so that we can see whether or not movement is being recruited into the thoracolumbar segment, upper, mid, and all the way down to the base of the sacrum, which indicates that the L5, S1 motion segment is in fact moving. So Hannah, we're going to have you do a lumbar flexion. So first I want you to just drop your head forward, drop your chest down, and bend forward as if you're going to touch your toes. Again, with the shirt up and out of the way, we look for cranial to caudal recruitment of motion from thoracolumbar all the way down into the lumbosacral motion segment. If your patient's painful, don't have them stay there too long. Okay? Discogenic instability can show itself with two particular visual indicators. One of them is called lordotic retention. So we're going to have Hannah try to demonstrate that for the video. So Hannah, I want you to try to flex forward, but try to retain your lordosis at the same time. Do you see how the back's pretty straight, almost lordotic in nature, and you would see that lordosis if her shirt was a little higher. Okay? As a patient right now, our patient is unwilling to flex their spine. Okay? That's a big clinical indicator, potentially, of instability. Now, some clinicians will interpret that this means that our patient's stiff, but during a side-lying examination procedure of passive segmental flexion, we'll be able to show that that's not. Again, that's called lordotic retention. Okay, the patient retains their lordosis. They essentially just flex from their hip, and they're unwilling to flex their lumbar spine. Pretty big clinical indicator of discogenic instability. Okay? Another subtle visual indicator of instability in a forward direction, okay, in the direction of flexion, is how a patient returns from a flexed position. So Hannah, let's show that where you tuck your pelvis up underneath your spine after you've flexed. Okay? So in this case, our patient has some instability in a forward direction too, but they are willing to flex. Okay, but watch how Hannah comes back up again. Her knees bend and her pelvis gets tucked right up under her spine. If you see that movement pattern, that is a visual indicator of potential instability at one of the lumbar motion segments. And again, we'll help confirm that further with passive segmental flexion and passive segmental translation.